All right, we'll go ahead and get started. Good afternoon and good evening, everybody. My name is Michael Awad, and I'm a minimally invasive surgeon at Washington University in St. Louis. And tonight we will be co-hosting and welcoming you to the annual SAGES ABSITE webinar, Part 1. This is a longstanding tradition for our society. We're coming up upon 10 years of offering this. And we're so excited to welcome attendees from around the world for this session. Tonight, we'll be going through a series of questions and helping you to prepare for whether it be the ABSITE, general surgery exams, or any other just general review. We have a phenomenal panel of panelists and co-hosts, which we'll introduce to you here shortly. The session is being recorded and will be available to you on the SAGES website and YouTube channel afterwards. We will be monitoring the Q&A, so if you do have questions as they come up, please feel free to put them in. Although the chat itself is disabled, you can post questions in the Q&A as well. So with that in mind, we'll go ahead and kick off. I'm going to bring up just a couple of slides to orient us. Again, this is our annual SAGES webinar. This is part 1, and part 2 will be coming up in January. Our agenda for this evening, and I'll introduce my co-host here, Dr. Ivy Haskins, shortly, and then she'll kick us off with an introduction of our first speaker, Dr. Olivia Haney, who'll talk about esophagus, stomach, and obesity. Dr. Jeff Blatnik will be going over general abdomen, hernia, and spleen. Dr. Pat Sylla will be going over colorectal and anal disease. And finally, Dr. Shanley will be going over small intestine, biliary disease, and flexible endoscopy. I want to just mention the society that really made this all possible, and really one of the professional societies that I hold nearest and dearest to my heart, which is SAGES, the Society of American Gastrointestinal Endoscopic Surgeons. SAGES is, again, a international society that served as really one of my first homes professionally that welcomed me into both the fields of minimally invasive surgery, but also as an educator. And since then has helped to launch my own career in surgical education, has been a phenomenal home for me professionally. We hope that you all are SAGES members, and if not, we welcome you to become them. There is a SAGES candidate rate, which is a wonderful entryway to become a part of SAGES. SAGES' vision is to reimagine surgical care for a healthier world, and its mission is to innovate, educate, and collaborate to improve patient care. Our values, as you can see here, include inclusivity, innovation, service, excellence, global community, and of course, fun. And again, many membership benefits to being part of SAGES. You get discounts to the annual meeting. The educational materials that SAGES provide are top-notch. From the videos, the webinars, we have both virtual and hands-on courses for residents and fellows, online learning, a network of 7,000 colleagues from around the world, an online subscription to our journal, Surgical Endoscopy, many research grants and career development awards, and again, leadership opportunities. And again, many membership categories, including candidate levels for those of you that are residents and fellows, medical students, and others. So sages.org/membership, encourage you to join if you have not already. And we would love to see you in Cleveland, Ohio. Coming up in April of 2024 is our marquee event, our annual meeting. A phenomenal program put together by Mary-Lise Buttrose, Caitlin Halbert, and Eric Paulai. I know they have an amazing program planned, and we hope to all see you there in person. It's going to be a tremendous, tremendous meeting. So just a little bit about our content for this evening. This is based on the ABSITE content outline. This is American Board of Surgery in Service Training Exam. And this has, tonight, we will be covering the kind of first half of these topics. In our part 2 webinar in January, we'll be covering the second half of these topics. So between the 2 sessions, you'll get a comprehensive review of all of the topics on the ABSITE that is coming up at the end of January. We will follow a similar format to years past, where we'll have multiple choice questions, and they'll be fairly rapid fire, but at the end of each question, we will have a Zoom poll that will come up on your screen. You will answer the Zoom poll, and then we'll kind of go over the responses. We'll discuss why the answer was correct and even some of the incorrect answers and why those were not the correct choices. One of the things we're so excited about this year is our question bank has been derived from TrueLearn. Many of you are familiar with TrueLearn, but these are a set of smart banks, which are high quality exam style questions that provide you with analytics. You can make your own quizzes. It goes using learning science principles and individual testing behaviors. And this is really a phenomenal tool for preparing for both formative and summative high stakes exams. TrueLearn.com to learn more. And we'll actually have live demonstration of the two TrueLearn question banks this evening. So with that in mind, we're going to go ahead and transition. I would like to introduce my co-host for this evening, Dr. Ivy Haskins. Dr. Haskins is known to many of you as a phenomenal minimally invasive foregut surgeon. She's based at the University of Nebraska Medical Center. She's director of the Esophageal and Swallowing Center in the Department of Surgery and is a foremost surgical educator. She has already established herself as a preeminent leader in our society and SAGES, has done phenomenal work within the Resident Fellow Training Society, our Fellows Career Development course, and many, many other things. So phenomenal to welcome her as a co-chair this year. Dr. Haskins, welcome, and happy to have you, and also to introduce our first speaker.
Thanks, Mike, for having me. And I would echo all of the reasons for why you should join SAGES that Mike already mentioned, because it's a great organization. I have the pleasure of introducing our first speaker, who is Dr. Olivia Haney. She is part of the Northwell Health System in New York. She does bariatric surgery as well as general surgery, and she is also one of the associate program directors. And she will be talking tonight about esophagus, stomach, and obesity.
All right. Thank you, Dr. Awad and Dr. Haskins. I really appreciate it. I'm really excited to kick off the evening. Apparently, I'm tasked with just making sure everyone stays on for the whole thing. So I have to make it sound really, really awesome. Okay. So our first question, we're just going to start and I'll read the answer choices and then we'll do the poll and then I'll go through the answers. So the first question is, a 16-year-old female with trichotillomania is presenting with vague abdominal pain and early satiety for approximately 1 month. Her upper GI series shows a filling defect occupying the contour of the stomach. So what is the next step in management? A, endoscopic removal. B, porcloprosine. C, papain or cellulase. D, partial gastrectomy and removal of the Bezoar. Or E, gastrotomy and removal of the Bezoar. All right, so we're going to give you a second to put your polls up.
And for everybody, you should see a Zoom poll coming up on your screen, A, B, C, D, or E. Please answer. And then in a few seconds, we'll close out the poll. And Dr. Haney will lead us in a discussion of the correct answer.
All right, I think we have, we're getting there. Yeah, you can probably close it out.
Yeah, I think we're good to continue.
All right, so this is really interesting, and what I thought it would come across the two fit like almost 50-50 between A and E, because a lot of people want to try endoscopic things nowadays for management of these types of things. But the reason why you can't do endoscopic removal, and the answer is actually gastrotomy and removal of the Bezoar, is because it's much too large. So if you would try to go in, it's the question stem says that it's showing a filling defect in the entire contour of the stomach. So the entire stomach is filled with the Bezoar. So there's no way you could chip at that endoscopically. And also you really risk damaging the esophagus, dragging that through. And so the gastrotomy is actually in the anterior stomach away from the duodenum, and you take it out that way, then close it up. The stomach is very forgiving. You're able to take it out that way. So that's why E is correct here. And it's interesting. A lot of people, we chose this question particularly because a lot of people go for endoscopic removal. All right.
Haney, I'd like to kind of point out some features here. So this
Yes,
is
please.
the TrueLearn website that is live. You'll see, in addition to the question, you'll see a percentage of how people nationally answered this question. So it can kind of gauge, and you'll see that actually only a quarter of people answered E, which is the correct answer. So if you didn't get it right, don't worry, you're not alone.
You'll
It's
see
just,
our members actually thought they got it right more percentage wise.
that's right. That's right. Yes. And the bottom line answers on the top right, but there's a very nice explanation, rationale, pictures, and it talks about why the other answers were not correct, as well as some relevant references. So a great tool that we have at our disposal this evening. Thank you. And next question.
Perfect. So our next question is: a male patient comes with gastroparesis, comes to the office with persistent complaints of bloating and inability to tolerate a diet. He is normoglycemic and has tried dietary modifications as well as medical therapy like metoclopramide or erythromycin. The most appropriate next step in management is A, pyloroplasty, B, increase the dose of metoclopramide, C, endoscopy with stent placement, D, jejunostomy feeding tube, or E, add cisapride to the medical management. All right, so we'll give you a second here to decide. So this is one of those next best questions, just like before. And we tried to pick the not slam dunk questions. So don't think all TrueLearn questions or all ABSITE questions are going to have 26% correct. So. All right, perfect. All right, so good job. Most of you guys got this one right. Obviously, it's a surgery test, so the surgery option's always a good choice if you don't know the answer. So pyloroplasty is the option here because it's refractory to medical management. So they've tried dietary modifications, they've tried medical management. You don't just want to keep going up on the dose of Reglan because it can have a lot of side effects. These endoscopic measures haven't been shown to be as proven to work with as such as a surgical pyloroplasty, and then a feeding tube, and TPN is obviously the last resort. So pretty good, pretty straightforward. All right, next question. All right, oh, I gotta move my polls. All right. This is a 67-year-old man presents to the clinic complaining of dysphagia. An EGD is performed that reveals a 5-centimeter freely mobile submucosal lesion in the distal esophagus. Which of the following is the most appropriate next step in management? A, biopsy to rule out esophageal cancer followed by definitive surgical resection. B, right-sided thoracotomy, limited esophagectomy with anastomosis. C, endoscopic mucosal resection. D, left thoracotomy with tumor enucleation. Or E, Ivor-Lewis esophagectomy. They've given you every choice here, from very minimal to very not minimal.
Dr. Haney, appreciate your test taking tips, that STEM, the appropriate next step is often a key part of that, even though there may be multiple appropriate answers, is that next step that's the clincher there.
Sometimes it'll trip you up. All right. Oh, okay. We have a little bit of a split amongst our answers, and so did TrueLearn. So this is interesting. So this is leiomyoma, and this is actually pretty like pathognomonic for it. The smooth-walled submucosal lesions in the distal third of the esophagus on a barium swallow. So this is one of those things you sort of have to, as a trainee, memorize kind of those key words to know that's what they're trying to get at. That you don't need to biopsy it. And actually they're saying if you do biopsy it, it makes further resection actually more complicated. They're more commonly in the middle or distal part of the esophagus. And that's actually just due to the anatomy of the esophagus. If you can read the explanation for further detail. And then the thing that I always learned when I was a medical student was, the military march where it's like left, 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 right, left. That's the thing. So left, right, left, that's top, middle, bottom. So those are how you do the thoracotomies. So for the lower third, it's back to left. So that's how you get to the distal esophagus. So And all you need to do is enucleate it. And that's the answer for this leiomyoma. There's your tidbit, Dr. Awad.
Great, great. I love it. I've not heard that one.
You haven't heard that? That must be a Southern thing.
No, I learn something new every time.
I didn't sing the song though, so
Yeah.
I guess that's good. All right, so the next question is, a 44-year-old woman, 4 years after a laparoscopic adjustable gastric band, presents with erythema and tenderness at the abdominal port site. Abdominal x-ray shows a gastric band positioned from left lateral superior to right medial inferior with a phi angle of 40 degrees. So which of the following is the most likely underlying diagnosis? A, marginal ulcer, B, band slippage, C, a kink in the tubing, D, prolapse of the proximal stomach above the band, or E, band erosion into the stomach. So to answer this question, you sort of have to know what the phi angle is and what that means. So kind of think about that. And then also knowing complications of bariatric surgery. You'll have a couple questions like this on the test. So they're pretty easy points if you can just remember that. All right, I think we're pretty good here. This was my favorite one because it was bariatric, so it's I don't have the show explanation yet, but you can go ahead and hit that, Betty.
You know what? I did it on my screen. There we go. Just a slight delay. Sorry.
Oh, no, it's okay. Thank you, Dr. Awad. So this is a band erosion into the stomach. So important things here. So the phi angle is important to know. This is a normal phi angle. So anything like less than 60 degrees, they say 58, but is pretty much considered normal. Basically, a slipped band is a band that goes like this. So the bigger the angle, the greater the slippage. There's no slippage on this, the way that they stated it. Erythema and tenderness around the port is basically, again, pathognomonic for band erosion into the stomach. Almost every time you have a port infection like that, it's going to be a band erosion. How you diagnose it, if they were to ask you that, would be endoscopy, and then you can remove it laparoscopically with like an omental patch if you need to. But that's something you should just like know off the top of your head. Easy points. All right. A patient with early satiety. Oh, it moved in front of me. Hold on. A patient with early satiety and weight loss has an upper endoscopy performed with biopsies that describe a low-grade mucosa-associated lymphoma. CT scan shows evidence of enlarged perigastric nodes, but no other signs of distant spread. This patient is best treated with A, antibiotics, B, chemotherapy, C, radiation, D, endoscopic excision of the mass, or E, wedge resection of involved stomach and associated lymph node dissection. Again, the full gamut of options here for you to choose from. Oh, this one, you guys are going to nail it. I'm feeling it. Oh, man, they were so fast. I think they're good on this one.
Olivia, if we only had you there for moral support when people were taking the actual website, everybody.
Right? You're just have my voice in your head like you're doing great. You have to be your own moral support, unfortunately.
Yeah.
So the answer here, this is like a really good give me question because there's 3, and you can see here, depending on the grade of the lymphoma, it's easy to get. So a low grade MALT tumor is, and you just treat it for H. pylori. That's pretty easy to get. It seems like most TrueLearn people got it. You guys all got it for the most part. So you treat the H. pylori. High grade lymphoma, that sometimes also is a question. You would do chemotherapy and radiation. Surgery is rarely indicated for this disease. They will try to trip you up on this question. Don't get, like they said, don't fall into the trap. But most of the time, if you pick antibiotics, you'll be right. Like 60% of the right time, you'll be right every time, something like that. Yeah. All right. Next question. Oh, another bariatric question. Good. All right. So 62-year-old man with a history of diabetes, frequent alcohol. Oh, this is a bariatrics. Frequent alcohol use, hiatal hernia, presents with hematemesis following a 1-day history of forceful vomiting. His temperature is 99.5 degrees Fahrenheit, pulse is 95, blood pressure 105/58. and the pulse ox shows an oxygen saturation of 98%, so relatively stable. Labs are significant for a hemoglobin of 8.4. The patient is started on crystalloid and for resuscitation and planned for emergent upper endoscopic evaluation. What infused product below should be started immediately? A, propranolol, B, histamine receptor inhibitor, C, proton pump inhibitor, B, RBC transfusion, and E, fresh frozen plasma transfusion. All right. Ooh, good job, guys. All right, we can probably move on. Perfect. Good job, everyone. This is also kind of a gimme. So for patients with Mallory-Weiss syndrome, high-dose proton pump inhibitor is proven to decrease the transfusion requirements. So it has to do with the pH of the stomach and the coagulopathy in a more acidic environment. So you can read all of that, but it sounds like you guys already know it. So we'll move on. All right, the next question here is a 55-year-old man who presents to his primary care physician with longstanding chest pain and a dry cough. This worsens after spicy foods. He has taken antacids in the past with minimal success. He is sent for an upper endoscopy. The esophageal biopsy shows intestinal metaplasia with goblet cells. Low-grade dysplasia is confirmed by 2 pathologists. The patient is sent to the office for a discussion of possible surgical management. Which of the following is true regarding management of this patient's disease? A, after undergoing anti-reflux surgery, endoscopic surveillance is no longer indicated. B, anti-reflux surgery is superior to medical therapy in preventing esophageal adenocarcinoma. C, all patients with known dysplasia require esophagectomy. D, this patient should undergo endoscopic surveillance every 6 months for a year, followed by annual surveillance. And E, Nissen fundoplication is contraindicated in patients with low-grade dysplasia. That one has a lot of words. Yep, good job, everyone. Perfect. You can probably close the poll. Great. You guys nailed it. This is also one of those that you should just know like the back of your hand, knowing what to do with low-grade dysplasia. Don't let them trick you up like with the anti-reflux surgery superior to medical therapy. That's never been proven to reduce cancer rates. All those things, you guys can look at it, but you guys did a great job. You're supposed to surveil every 6 months and then for a year, followed by annual surveillance. Perfect. All right. A 45-year-old woman presents to the emergency department with complaints of chest pain after an episode of severe retching an hour ago. She has a recent diagnosis of achalasia that has not yet been treated. Key point here. On exam, the patient is hemodynamically stable with mild leukocytosis. An upper GI study shows a very small leak in the distal esophagus. The most appropriate next step in management is A, esophagectomy with gastric pull-through, B, cervical esophagostomy and gastrostomy feeding tube, C, esophageal stent placement with VATS, drainage of the left thoracic cavity, D, contralateral myotomy with debridement of esophageal defect and primary closure of the intercostal flap placement, or E, non-operative management with antibiotics and NPO only. All right.
A little bit of a tricky one.
Yeah, interesting. A little split here. All right, I guess. Okay, all right, about 50-50. So we'll spend a little more time on this one. I think this one's tricky just because, you know, we are so used to doing non-operative management with patients with very small leaks for esophageal perforations. But the key point of this question is that the patient has achalasia that's not treated. So if you don't treat the achalasia, the leak will not heal on its own because of the high pressure system. So you have to treat the achalasia. And to do that with a patient that's stable, you would do this contralateral myotomy, debride the esophageal defect, primarily close it with, and then do some sort of flap, which, you know, an intercostal flap placement is a good option here. So this is something that, you know, we do a lot of non-operative management for esophageal perforations, but the trick for this question is you have to treat the achalasia. So don't let that kind of trick you, and just make sure you read the question really thoroughly. All right, almost here. We're almost moving down the body. A 34-year-old man with no significant medical history is referred to a gastroenterologist for a history of dull, recurrent epigastric pain that worsens shortly after eating. EGD shows a clean-based ulcer just proximal to the pylorus and is otherwise normal. What type of ulcer does this patient have, and what is the ulcer's etiology? So basically, okay, go ahead. You guys can do your poll. But basically, this is just a memorization question, right? You just have to remember the types of ulcers, and then which ones are associated with acid and which ones are associated with NSAID use, which you guys should nail. Oh, I'm going to put the poll up, I think. There you go. I'm going to discuss some test taking skills while we do this. So there are 2 answers that have type 3 ulcer in it, and then they have 2 associated NSAID versus acid secretion. That should probably give you an answer of what it is just based on how they wrote this question, but maybe the American Board of Surgery won't be as easy as that. So I gave it away. All right. Perfect. So, all right, we're actually about in line with the true learn answers here. So this is just kind of rote memorization. Google this, look at a picture of the types of ulcers. There's a nice picture there. 2 and 3 are the ones associated with acid. You can just, increased acid secretion. You guys can just remember that it's pre-pyloric. Both of them have that. So those are the 2 that are the same. 5 is the NSAID. That's easy to remember. And then decreased mucosal protections are 1 and 4. So it's just rote memorization. Also, a key point here is for gastric ulcers, you do want to consider biopsying them because they have a much higher chance of cancer than duodenal ulcers. So that might be in the question. All right, next one. All right, a 76-year-old man presents to the office complaining of dysphagia. Upon further questioning, he admits that he has at times regurgitated undigested food and has also been having extremely bad breath. An esophagram is shown below. Which of the following best explains the pathophysiology behind his disease process? A, mucosal herniation through an anatomic weakness superior to the cricopharyngeus muscle. B, absence of esophageal peristalsis and failure of the lower esophageal sphincter to completely relax on swallowing. C, mucosal herniation through the anatomic weakness between the middle and inferior pharyngeal constrictor muscles. D, mucosal herniation through an anatomic weakness superior to the thyropharyngeus muscle. Or E, esophageal diverticulum involving all the layers of the esophagus. This is also just one of those questions you just have to know the anatomy for the process. So it's kind of like an either you know it or you don't question on the ab site itself. So if you don't know it, I would not recommend spending a lot of time trying to guess. Pick something, move on. Don't waste your time if you don't know it. Also, test taking skills. If you think about it, A and D are very similar. So you can kind of decide, like, do you think it's above or below? So you guys did really well. So good job knowing all your anatomy. Just look at the picture. A is the correct answer. So, you know, it's a Zenker's. You just have to know where Killian's triangle is, and you guys did a great job. Perfect. All right. One more, I think, right? Or was that the last one?
We do have one more. And
I thought there was one more.
Just reloading here, sorry.
No problem.
All right.
All right. Oh, good. Okay. A 26-year-old woman with no travel history presents with dysphagia to solids. She states food gets stuck in the middle of her chest, but does finally pass over time. Esophageal manometry shows aperistalsis and a barium esophagram is performed, see below. An EGD is performed. There are no definitive masses. The lower esophagus is biopsied. So what would likely be seen on the biopsy of the lower esophageal sphincter? A, Staph aureus organisms. D, dysplastic cells. C, normal esophageal tissue. Trypanosoma cruzi organisms, or E, T cell and eosinophil infiltration of the myenteric plexus. So this is kind of one of those things, you got to know what that picture is, and then you have to know how the pathology looks for that type of process. This is also kind of one of those you know it or you don't questions. All right, we're probably good there. All right, so most people did get it right. This is one of those questions where, like I said, you kind of have to know it. That's a pretty classic picture of achalasia. They also describe it on the manometry. They describe it pretty classically. And that's just something you have to know about the T cells and the eosinophils about achalasia. The etiology is not well understood. But just bonus test taking skills, that's the longest answer. So sometimes that's the right answer. But if you don't know it at all, picking the longest answer could be the right answer. Just saying. That's my last tidbit for you, Dr. Awad.
Dr. Haney, thank you so much for that wonderful overview of esophagus, stomach, and obesity. I wish I had you over my shoulder when I was taking the ABSCITE as a resident. Thank you so much for your expertise.
You're welcome. It was fun, you guys. I hope everyone sticks around for everyone else. All
right. Next, we'll transition to Dr. Jeff Blatnik, who will be leading us in the discussion on in general abdomen, hernia, and spleen. Dr. Blatnik is a great colleague, my partner here at Washington University in St. Louis, and quickly become one of the world's leading experts on abdominal wall disease and core health. He himself is also a leader in SAGES, America's Hernia Society, has developed some of the guidelines for how we describe mesh products, and that has taken up by industry, and also has written a fascinating opinion piece in the New York Times recently on abdominal wall hernia repair and training. Dr. Blatnik, thank you so much for being here.
Thanks for having me. This is a great thing. I agree. I wish I had this when I was a resident. I just want to clarify, I am not a good enough writer to actually write something for the New York Times. So please don't assume that I am a good writer or anything like that. But we'll try and get through some questions here today on hernias, hopefully give you some tidbits about where they are, similar to Dr. Haney from the last session. So we'll jump right in and try and get through these 13 questions on time. All right, question number one, a 22-year-old male presents to the emergency department complaining of abdominal pain. The patient reports that the pain started suddenly. Physical examination reveals tenderness to palpation in the right mid-abdomen, just lateral to the rectus muscle. Which of the following is true regarding Spigelian hernia? So they're not asking you to diagnose what it is. They're asking you some facts about Spigelian hernias in general. So we'll open up the poll. For me, I always had trouble with those key things. What's the next best answer? Which one of the following is true? Which one of the following is false? And so I think it's really important, at least I knew as I was taking on these exams and the boards, to just take your time and make sure you read the question very slowly, because otherwise they'll sneak some little facts on you. So this one's pretty straightforward. You guys actually did much better than the true learn population. So about 90% got the correct answer right. So it's located between the linea semilunaris and the lateral edge of the rectus muscle. You know, it's a little odd for a 22-year-old to get a Spigelian hernia, but they tell you what it is. And so they're really just asking you for some facts about Spigelian hernia. And so I think we'll just kind of move on since everybody got that one right. We want to start with some softballs, and then we'll get a little more difficult. All right, question number two, which of the following increases the risk of developing a surgical site infection after synthetic mesh repair of a ventral hernia? Everybody's least favorite thing to deal with as a hernia surgeon. A, affixing mesh in an interrupted fashion. B, use of a biologic mesh. C, placement of mesh in an underlay fashion. D, drain placement. Or E, large pore, lightweight mesh. I think, again, this is just something you have to have some exposure and some experience to, but just kind of go through all the different choices and try to come up with the best answer. A little bit of some diversion in the answers there. So let's see what the correct answer is. D, drain placement. So of the group here, about 57% got that right. There was some people who thought C and D were also, or C and E, I'm sorry, were also possible answers. I think in general, most of us agree that large pore lightweight meshes tend to have some lower risk for infection. And then again, the underlay fashion. So in general, between those muscle layers, tends to have a general consensus of lower risk of infection in comparison to an on layer on top of the muscle, just because of the potential for surgical site infections continuing down to the mesh itself. So D, drain placement, is thought to be the right answer here.
All right.
All right, question number 3. A 45-year-old woman presents to the office for evaluation. She states that she noticed a midline bulge when she strains, but not at rest. She's had 3 children in the past 5 years. She has no other pertinent medical or surgical history. On physical exam, a bulge is present in her midline epigastrium with Valsalva maneuver, which disappears at rest. There is no palpable hernia or fascial defect. Which of the following is true? A, laparoscopic repair is recommended. B, the hernia usually contains preperitoneal fat. C, simple suture repair is suggested. D, treatment is with abdominal wall strengthening. Or E, incarceration is common. So while you guys think about that real quick, just to answer, there's somebody asked a question about what about seroma in the last question. That is certainly a concern. I think most of us actually will still use drains. Obviously, hernias cover a whole spectrum of people. So I think we will use drains, but at least in our practice here is early removal of the drains to try to reduce some of those infection risks. All right, good. So the answer here is D. So this is a diastasis question, which honestly, I'm pretty surprised to see this on the app site, because historically this would be considered a plastic surgery problem. But to be honest, we see more and more patients who present with a diastasis, or actually more often present with a hernia in the setting of a diastasis. And there's certainly a lot of things to take into consideration that we hadn't considered historically when it comes to fixing this. But I think in this situation, the right answer is treatment with abdominal wall strengthening, of trying to bring those abdominal wall muscles back to the tone that they used to be prior to a pregnancy. There's certainly some controversy here in practice, but as far as the test is concerned, abdominal wall strengthening is the right answer here for a diastasis. So you got to be able to recognize the diagnosis and then come up with your treatment plan. All right, question number 4. A 54-year-old man with a history of chronic pancreatitis presents to the emergency department with bloody bowel movements and occasional hematemesis. An EGD is performed and shows isolated gastric varices in the fundus, no esophageal varices, but no active bleeding. Ultrasound demonstrates no portal hypertension. What is the best management choice for this patient? A, sclerotherapy. B, banding. C, transjugular intrahepatic portosystemic shunt procedure or TIPS. D, splenectomy. Or E, gastrectomy. I think there's a couple things here. First, you have to figure out what the diagnosis is, and then they want you to figure out what the best management is for this patient based off of that diagnosis. So 2 parts you have to be able to sort out along the way. All right. Good. So general consensus here, most people felt D was the right answer, right in line with kind of how the TrueLearn population answered. So the correct answer here is splenectomy, and that would be the treatment for a symptomatic splenic vein thrombosis that's causing his gastric varices. The repeated episodes of pancreatitis and the inflammation is thought to be the source of the thrombosis, and isolated thrombosis of the splenic vein will usually just cause the splenic venous hypertension, which gives the collaterals from the spleen into the gastric fundus itself. So a couple key things you have to be able to pick out of that stem there to know that it's splenic vein thrombosis, and then ultimately the treatment for that is splenectomy. All right, question number 5. A 45-year-old woman is undergoing a transabdominal preperitoneal laparoscopic inguinal hernia repair. A large piece of prosthetic mesh is placed over the affected area. Which of the following areas should be avoided in placing tacks to secure the mesh? A, Cooper's ligament, B, the pubic tubercle, C, the posterior rectus musculature, D, superior to the iliopubic tract and lateral to the gonadal vessels, or E, inferior to the iliopubic tract and lateral to the gonadal vessels. So a couple different things you have to look at. Make sure you read the anatomy part right, the medial to lateral, the superior to inferior, as you think about where you're going to fixate this mesh for an inguinal hernia repair.
And Dr. Blatnik, looks like this is another one where you can kind of, mutually exclusive answers, D and E, probably clue into one of those being the right one. What do you think?
Yeah, I agree. I think, obviously, for me, when I'm taking tests, I usually try to see, do I know the answer? And if I know the answer, then I kind of go along. But sometimes, it gets trickier. You narrow it down to one or two. And so trying to narrow those things down even further when you can't decide whether it's one or the other is trying to take into consideration some of those different variables that they put in along the way. So good. So about 72% or 3/4 of you got the correct answer, which is E, actually very similar to the way the TrueLearn population answered it. And I think the key thing here, as seen on that pictures, is remembering your triangles, right? When you think about triangles and hernia repair, there's the triangle of doom and the triangle of pain, especially when it comes to fixation. The triangle of doom usually involves the iliac vessels. The triangle of pain is where you're going to catch most of those nerves. And so that's going to be inferior to the iliopubic tract and then lateral to the gonadal vessels. And so you can see that represented there on the picture. All right, question number 6. A 52-year-old woman with a history of laparoscopic splenectomy for ITP presents to the office for her follow-up visit. She explains that she's continuing to have nosebleeds and gingival bleeding and that her symptoms have not improved. What is the best next step in management? I think some things that would be helpful here. You don't really know how far out she is from her splenectomy, whether it's recent or more remote. I think that would be some additional helpful information. So you have to kind of just take the information that you have and try to figure out what the next best thing is. So sorry, I didn't read the answers. A, restart her steroids. B, initiate intravenous immunoglobulin. C, perform a CT scan with contrast. D, send for a peripheral smear. Or E, re-exploration. All right. Let's see how we did. So good. So the majority of people got the right answer. It's D, send for a peripheral smear. Although obviously there's kind of a little bit broader mix of answers along the way. I think the key thing here is to figure out what's going on. And so this patient here is having persistent symptoms, which most likely is related to an accessory spleen after splenectomy. And so in that situation, a failure to improve is where you really just need to make the diagnosis. So this first needs to be done by getting a peripheral smear. You're going to look for hollow jolly bodies, which are only present in complete asplenia. And so if you see those, then that should give you an idea that's what's going on. So I think the first answer here is to confirm the diagnosis of where things are. Question 7, an 80-year-old man is referred to the office for an inguinal hernia repair. The patient cannot tolerate general anesthesia. He's brought to the OR and sedated. Where is the most appropriate space to inject local anesthetic in this patient? So you're going to do a back inguinal hernia repair. A, midway between the anterior superior iliac spine and the pubic tubercle. B, 1 centimeter medial and 1 centimeter inferior to the anterior superior iliac spine. C, at the pubic tubercle and Cooper's ligament. D, 2 centimeters medial and 2 centimeters superior to the anterior superior iliac spine. Or E, 2 centimeters medial to the anterior superior iliac spine. So a little bit confusing, lots of different numbers, locations, and things. And this is probably one of those questions for me where I'll kind of almost work backwards. So I'll kind of exclude things that I know, okay, well, that one's not right, that one's not right, and kind of narrow it down and then really focus in on some of those nuances of the question. So, a few of these are very similar. I'll get rid of the ones that are clearly not right and then work backwards from there.
There's going to be some discussion on this one, I think.
Yeah, I think it's just, it's kind of an area of where things are. And to be honest, the difference between 1 centimeter and 1 centimeter inferior and 2 centimeters medial, and it's the superior aspect that I think is a little bit more important there. So it's not so much the 1 to 2 centimeters medial. Again, I think you make the argument either way, but it's the fact that you're going to be superior to the anterior superior iliac spine. And when you think about how the nerves come around, again, the ilioinguinal, iliohypogastric, which you're trying to block, most of the time they'll actually be superior to the iliac spine. And so that's why you want to be there. Just again, kind of narrow down the things that aren't right, and then just kind of knowing the facts along the way about where the nerves run can certainly be helpful. So maybe some people will take some information back from here and do a better job of blocking further inguinal hernia repairs under sedation. So D is the correct answer, 2 centimeter medial and 2 centimeter superior, and then just kind of knowing where the nerves run. Question number 8, which of the following best represents the rationale for splenectomy in patients with immune-mediated thrombocytopenia who have failed medical management? A, improvement of pancytopenia and reduction of need for transfusion. B, relief of abdominal pain and early satiety resulting from splenomegaly. C, removes the site of sequestration of abnormally shaped platelets. D, removes the source of antiplatelet antibodies that lead to platelet destruction. Or E, removes the source of properdin and tufsin to prolong the lifespan of platelets. So again, I think this one's going to be a little bit back and forth here as well. And ultimately, when I was looking through these beforehand, I kind of missed it as well the first time. All right, so I think we've got a majority, so let's see what happened. So the correct answer here is D. So a little bit, 44% of the group here tonight got this answer right. So the correct answer here is D, removes the source of antiplatelet antibodies that lead to platelet destruction. I think the reason why C is incorrect is, as TrueLearn tells us, the hereditary spherocytosis results from abnormality in the erythrocyte membrane proteins that leads to more spherically shaped RBCs, not platelets, which are ultimately sequestered and destroyed in the spleen. So what it's talking about is red blood cells versus platelets. So it's just a matter of reading the question really closely, knowing a lot about how that spleen works and what's going on. So the correct answer here is D, antiplatelet antibodies that lead to platelet destruction. Question number 9, which of the following nerves is most commonly injured during laparoscopic inguinal hernia repair? Ilioinguinal, B, iliohypogastric, C, genital-femoral, D, obturator, or E, femoral. Again, so you got to know laparoscopic inguinal hernia repair. You got to know kind of where you're likely to injure and where those nerves run. Interesting. All right, so let's see. So we got a good mix of answers here, about a third split between A, B, and C along the way. And I think the key thing here is it's talking about laparoscopic inguinal hernia repair. So open inguinal hernia repair, right? That's where your ilioinguinal, iliohypogastric are going to be more in play, as you can see there in that graphic provided by TrueLearn, and kind of with the tension-free or Lichtenstein repair. But for a laparoscopic repair, if you're doing it right, as we learned in that previous question, not tacking into your triangle of pain and those sorts of things, the genital femoral nerve is going to be the one you're most likely to injure, as that runs usually along with the cord structures that kind of are where the mesh lays along the way. The other one you have to watch out a little bit for is your lateral femoral cutaneous. That was not an answer choice here. And so that's why that one would not be correct. I think if they had given that one a little bit more difficult, lateral femoral cutaneous usually on the lateral side as you're doing that dissection, that would be recognized by a patient who wakes up with severe pain along the lateral aspect of their thigh. All right, question number 10. A 57-year-old man presents to the emergency department with complaints of fevers, chills, and rigors for the past 2 days. His medical history includes a motor vehicle collision 2 years ago that required an emergent laparotomy and splenectomy. He received all the necessary immunizations after being discharged and was subsequently lost to follow-up. The patient becomes progressively septic as he is being evaluated and requires initiation of vasopressors. Which of the following organisms is most likely responsible for this patient's condition? Pseudomonas, Haemophilus influenza, Streptococcus pneumoniae, Capnocytophaga canimoris, Neisseria meningis. Whew. That's probably harder than the question itself.
I'm glad
So I
you're
think here,
not me.
yeah, great. I practiced beforehand. I still screwed up. So I think here you need to know the most likely organisms associated with asplenia. You know, it can be a little bit confusing because they talk about he had his immunizations, but again, he's been lost to follow-up, and so you need to figure out what's going on. Good. And our group is much smarter than the True Learn group here. Only 39% of the True Learn people got this right. 81% of you tonight got this right. So it's strep pneumo is the correct answer. And so in post-splenectomy patients, overwhelming post-splenectomy sepsis is something you need to pick up on. They made it pretty obvious that was what was going on in this patient. Strep pneumo is the most common cause that you'll see overall. Although these, as you can see there on the table, those are the other potential organisms that can all be associated with overwhelming post-splenectomy sepsis. But strep pneumo, most common one you may run into. All right, a couple more here, and then we'll pass things off. So this is question number 11. A 37-year-old man with a history of total abdominal proctocolectomy and ileoanal anastomosis for FAP presents to the emergency department complaining of abdominal pain, nausea, and vomiting for the past month. A CT scan demonstrates a mesenteric mass at the root of the mesentery that is keeping a portion of the small bowel, resulting in a partial obstruction. He's taken for diagnostic laparoscopy with a biopsy of lesion and lysis of adhesions. His obstruction resolves and the biopsy demonstrates fibroblastic proliferation in bundles of spindle cells and an abundant fibrous stroma. Which of the following is the most appropriate next step in management? A, repeat CT scan in a year. B, Sulindac and tamoxifen. C, neoadjuvant chemotherapy followed by surgical resection of the root of the mesentery. D, immediate surgical excision of the mass. E, radiation therapy. So again, you gotta be able to identify what's going on and then also what the treatment option for this is. Another mix of answers. We'll give you another minute to go through, and then we'll go over everything. All right. So let's see what they have to say. So similar to True Learn, we have a big mix of everything. So 32% of you also answered B, but about a quarter of people answered C and D. So, okay, you need to figure out what's going on. This is a desmoid tumor. You can figure that out based off of the pathology of things. And then you need to figure out what to do next. And so Sulindac and tamoxifen are usually first-line treatment options for it. You know, the problem with surgery right away is they tell you that it's located in the mesentery, at the root of the mesentery. And so resecting that urgently, whether it's immediate or any matter, is very, very difficult and potentially puts the patient at risk for small bowel. Neoadjuvant chemotherapy followed by surgical resection, same argument there. And then ultimately radiation and CT scans not recommended. So B is the correct answer here. So figure out what it is. It's a desmoid, and then ultimately what's the best treatment option for it. All right, well, question 12 is loading up here. A 43-year-old man is undergoing an open inguinal hernia repair for a large symptomatic hernia that has been present for 2 years. After opening the external oblique, a large hernia sac containing a loop of intestines is identified medial to the inferior epigastric vessels. Which of the following is the pathophysiology of this patient's hernia? A, weakness in the transversalis fascia. B, weakness in the floor of the inguinal canal. C, herniation of the peritoneum and contents through the deep and superficial inguinal rings. D, herniation of peritoneum and contents between the femoral vein and the lacunar ligament. Or E, defect in the external oblique aponeurosis. So first you have to figure out what kind of hernia it is, and then what's the anatomy that makes up that type of hernia. And this ultimately shows, I think, how the inguinal region is actually really complex and how all the different muscle layers come together. You know, a lot of people kind of chalk up an inguinal hernia repair to be an intern's case. But technically the anatomy, where all the muscle layers come together, how everything is interwoven in the groin is incredibly complex. And to be honest, took me a long time to get a good understanding of where things are. Okay, so this, a mix of answers from our group, very similar to kind of what TrueLearn group also said. So a couple things to take away here. This is a direct inguinal hernia. You can tell that by the fact that it's medial to the inferior epigastric vessels. So that gives you the type of hernia and then kind of understanding the anatomy. So a direct is actually a weakness in the transversalis fascia. That makes A the correct answer. The inguinal floor is actually made up of the inguinal ligament. And so that's not really where the hernia is going through. The transversalis fascia is actually what makes up the posterior wall, which is where the hernia itself comes through. So you have to think about it in 3 dimensions, where things are poking out and through. I think the other thing with some of the anatomy, as we think about it, it's kind of whether the patient's supine or upright can actually make a little bit of a difference. So if you think about it while looking at the patient, you're doing open repair, the floor is technically a wall and the wall is technically a floor. So think about it as if the patient's standing upright when you go through these different anatomical terms. All right, this is the last question for me. Cachectic 75-year-old man with rheumatoid arthritis, which is currently being managed with methotrexate and prednisone, undergoes an open right hemicolectomy for an obstructing cecal mass. On postoperative day 2, a tender bulge under the midline laparotomy with salmon-colored fluid soaking through the dressing is noted. What is the next best step in management? A CT scan of the abdomen pelvis. B, pan culture and administer broad-spectrum antibiotics. C, remove staples in a sterile fashion at the bedside. D, wound exploration in the OR. E, bedside reduction of a midline bulge. See how we do. All right, good. So what is everything's going on? The patient dehisced his fascia, right? So he has a fascial dehiscence. They give that to you pretty clearly. He's got a bulge under the midline. He's got fluid that's soaked through the dressing. For the junior residents out there, if a nurse calls you for somebody who's early post-op and says they just had a huge gush of fluid from their incision, it should be a fascial dehiscence until proven otherwise, especially in kind of the 2-day time frame that they give you in the stem. What you need to be a little bit more cautious of is, wound infections and those sorts of things tend to be delayed a little bit and won't be presented at 2 days. I think the next most common thing that a minority of people talked about was getting a CT scan. To be honest, yeah, some of these patients may get CT scans in the world nowadays, but ultimately, you know what it is. The treatment is to go back to the operating room and ultimately fix the problem at hand. So D is the correct answer here. Return to the operating room for surgical management of the fascial dehiscence. All right, everybody. Thank you. That's a lot of fun. Hopefully you learned something that will help you on the app site coming up in just a month.
Dr. Blatnik, thank you very, very much. It is a delight. There's a reason we keep asking you back year after year. I wish I could just transplant your brain into mine, but thank you so much for that excellent review.
Appreciate it.
Appreciate it. Now it's my distinct pleasure to welcome a very, very special guest for our session this evening, and that is Dr. Pat Sylla. Dr. Sylla is president of our society, SAGES, and is extremely busy individual, but committed to resident and fellow education, taking time out of her busy schedule to be here. And she is joining us transatlantically from Africa at the moment. So again, her dedication. Dr. Sylla is at Mount Sinai Health System, where she serves as the system chief for the colon rectal surgery program there. She's been renowned for a number of clinical advancements. In fact, did the first NOTES procedure via transanal approach. This is natural orifice transluminal endoscopic surgery for rectal cancer using a NOTES approach. She's had hundreds of publications, disseminations, key leadership positions in many societies, not only SAGES, but also as a member of the National Accreditation Program for Rectal Cancer Accreditation Committee. And again, a phenomenal leader in herself. And Dr. Sylla, thank you so much for being here. Really appreciate you being here.
It's a pleasure. Thank you, Mike.
She's going to lead us in a discussion of colorectal and anal disease. And your questions are coming up here momentarily.
Yes, it's a real pleasure to be here tonight, and I'm really excited to kind of talk and switch gears to colon, rectal, and anal disease, which is really important for the upside, obviously. So let's just kick into gear. First question, what is the most common long-term complication of ileal pouch anastomosis, or IPAA, for ulcerative colitis? A, pouch fistula, B, ilioanal anastomotic stricture, C, pelvic sepsis, D, pouchitis, and E, small bowel obstruction. Again, we talk about long-term complication. So after the immediate surgical event, specific to ulcerative colitis. Many cues here that you should be reading to it. Should we take a look? Did we get the poll? Oh, I'm sorry. The poll is at the bottom. Excellent. 87. Exactly. So chronic pouchitis is a real problem, up to 50% incidence by 2 years after pouch creation. Really quite unclear, requiring several courses of antibiotics. So the other close-up was ilioanal anastomotic stricture. It's not unreasonable, but not really long-term. This is something that would happen as a sequela of a leak or problem with the anastomosis. The majority of these anastomoses are done using a stapler. So you'd see the same complication with any type of colorectal anastomosis. So it would be very similar to that. So strictures is uncommon, it can occur, but it's not something that was specifically long-term in the ulcerative colitis patient. Okay, next question. A 67-year-old male is admitted to the ICU with severe pneumonia and respiratory failure. On hospital day 4, he is noted to have severe abdominal distension. Further workup establishes the diagnosis of colonic pseudoobstruction, otherwise known as Ogilvie syndrome. Which of the following is correct regarding this condition? A, trauma is responsible for about 11% of cases and is second most common behind metabolic imbalances. B, etiology is idiopathic or unknown in 95% of patients. C, pathophysiology involves both parasympathetic underactivity and sympathetic underactivity. That should be a trigger. Mouthful. Pain is a main clinical symptom. And E, perforation is most likely to occur in the transverse colon. So lots of cues here. Okay. So that's an interesting one. I think let's look at the explanation. So the most common, this is actually, we know some of the common causes for it, and trauma is definitely one of them. And as well as metabolic imbalances. We know there's other conditions like surgery, especially orthopedic surgery, but other type of surgical operations intervention can trigger Ogilvie syndrome, neurological condition like Parkinson's disease or spinal cord injury. So that's the reason why this question was most appropriate. If you look at the most common response was etiology is idiopathic or unknown in 95% of patients. And it's not really idiopathic if you look at etiology, meaning the conditions that are associated with this condition. So that's why the first answer was the best answer. The next most common response was pathophysiology. So I was saying it's a cue when you have parasympathetic underactivity and sympathetic underactivity, something doesn't add up, right? So be suspicious when you see something like this. But in truth, it's actually not quite the phenomenon that you see. It's believed that it's actually a result of parasympathetic hyperactivity. So you can see here in the answer, it's a parasympathetic. If you think of parasympathetic, my mnemonic for this is para is forward. So that tells you that's actually induces activity as opposed to sympathetic, which actually slows things down. So it's believed that there may be some interruption of the S2, S4 parasympathetic nerve fibers that are triggered, and that results in colonic distension. I think very importantly, yes, you guys agreed with the perforation being not the transverse colon. That's very important to know that it's actually the cecum that becomes the most vulnerable for rupture. That's something to look at for, and very important to diagnose early to avoid this dreadful complication. Okay, next question. A 27-year-old man presents to the primary care physician's office with pain on defecation and blood on the toilet paper. He typically has had hard stools and has strain. Which of the following regarding his condition is true? A, diagnosis requires biopsy. Remember, the patient is in pain. B, digital and proctoscopy exams are not necessary for diagnosis. C, symptoms frequently associated with fistula in ano. D, posterior location should prompt workup for other causes. And E, the usual location is the anterior midline. So let's take a look at the answers. I think all the risk factors for anal fissures is being listed here. I hope you definitely immediately identified the problem. Pain, combination of pain, bleeding in a setting of constipation is pretty pathognomonic for anal fissure. Patients are in pain. So, and this is actually a lesson we teach our fellows early on, if they haven't learned this during their residency, is never stick a finger in their butts when they're in pain in the emergency room. Just gently open up the butt cheeks and they should be able to visualize most commonly a posterior midline anal fissure. So the answer, yes, the majority said yes, digital and proctoscopy are not necessary for diagnosis. You should be able to visualize the fissure pretty easily. The usual location is anterior midline. No, you need to memorize this. It's posterior midline. It has to do with the blood flow to the posterior commissure. It's the least well-supplied area of the anal canal. So this is the area that's most vulnerable to tearing with in the setting of constipation and straining. So that is not the right answer. And 16% said symptoms frequently associated with fistula in ano. Fistula in ano are not painful. They're annoying. Patients have essentially chronically draining wounds, but they're not painful. So again, the combination of pain and bleeding in a setting of constipation, this is your trio. You need to remember the triad, and this is classic for anal fissure. Okay, next question. A 75-year-old man with known history of AIDS presents to the surgical clinic with a 5 months history of an anal mass and severe pruritus. Physical exam shows a necrotic mass extending from the anus just below the dentate line. Which of the following is correct regarding this type of tumors? And you have a very important picture. Try to memorize this. This is very classic for what they're trying to get at. A, basal cell carcinoma of the anus is very aggressive and tends to metastasize. B, Buschke-Lowenstein tumor is both histologically and clinically benign. Synchronous visceral malignancy is found in about 50% of patients with anal Paget's disease. The lymphatic spread from squamous cell carcinoma is mainly into intra-abdominal lymph nodes. Surveillance is not indicated in patients with we call it AIN. That's a shortcut for intraepithelial neoplasia after treatment. So let's see the poll. This is a tough question, but I think you need to know this. They seem to like perianal Paget's disease, ABSITE and colorectal boards. Very much popular question. You're going to find something on Paget's disease, which you all recognized, and that's very important. Excellent. Yes. So for those of us, and very few of you even knew, but this is really important. I think the pathognomonic finding is really this erythematous circumferential irregular lesion with some scaling. This is very classic. And I think the other answers are really important to know. Basal cell is usually the anal skin. That is not the case here because it's intraanal. Buschke-Lowenstein is a really aggressive form of HPV condyloma, and it is not benign clinically. It's very locally aggressive. Can you scroll down, Mike? I can't see there. And then the other ones is important to know that AIN, patients with AIN HPV infection need to be monitored for life. This is the HPV virus doesn't go away, so they cannot be ignored. And then I think there was another, for some reason I can't. Can you scroll down? There was another point I wanted to make. I can't see it on my screen for some reason. Below answer B, or question B, I'm sorry, option B. There was an important point made about another type of cancer that it was not reasonable to select. I can't scroll down.
The next answer was about squamous cell carcinoma.
Oh, thank you.
Oh, I'm sorry.
Okay, perfect. And again, that was unlikely because of the intraanal location. Oh, it was also, this is important. The spread of squamous cell carcinoma is not intra-abdominal nodes. It's actually inguinal nodes. That's something that every one of you needs to know for squamous cell anal SCC spreads to the inguinal node. That's what you have to examine the groin when you see those patients. So very important to know that for the future, because that will come up. Next question. Okay, a 57-year-old woman is post-op day 7 from a sigmoidectomy with primary staple colorectal anastomosis for recurrent diverticulitis. She has low-grade fevers and leukocytosis. She has not had return of bowel function. So that tells you she's not thriving. Her CT, her abdomen is mildly distended. A CT scan of her abdomen and pelvis reveals a 4-centimeter intra-abdominal collection in her pelvis. Percutaneous drainage reveals feculent fluid that grew E. coli and Bacteroides fragilis on culture. What is the most reasonable explanation for the source of this intra-abdominal collection? A, hematoma from poor hemostasis. B, failure to irrigate the field with normal saline. C, lack of mobilization of the splenic flexure. D, lack of operative drains placed at the index procedure. And E, absence of middle hemorrhoidal arterial flow. I love this question. I really hope everybody gets it right, because this is a really important question. There should be no debate about what this is and how you call this. I am so happy right now. Thrilled. So yes, you're exactly right. Some are a little bit, no. So 60% of you are correct. It is one of the major risk factors is the lack of mobilization of splenic flexure, meaning tension on the anastomosis that can result in an anastomotic leak. And that's what it is. This is a patient who's not thriving. Clearly there are issues. A CT scan confirms there's a collection near the anastomosis. That is an anastomotic leak until proven otherwise. And so there's some really interesting answers here. You need to be cautious about irrigation has never been shown to be protective or deter from leaks. So this is really not a risk factor in any analysis conducted to date. The perfusion is actually a good guess, except that it's not, the middle hemorrhoidal artery is not really relevant. The inferior hemorrhoidal artery supplies the rectum, so that would not be relevant. So that's something to know about the blood flow to the rectum. Very important to know. So this is actually a curveball they're throwing at you here. And then the other questions are pretty obvious. Hematoma is usually sterile. Lack of operative drains. Drains are a controversial topic. They actually have not been shown to prevent leaks. As a matter of fact, there's a small suggestion that they actually may cause leaks in some small randomized trials. Bottom line is, yes, it is tension as one of the major risk factors for anastomotic leak with a colorectal resection. Okay, next question.
Second, just reloading here.
No problem. This is question 6, yeah? Yeah. 25-year-old man presents to the surgical clinic with complaints of rectal bleeding and anal pain. Yes, he has no prior history of malignancy. On exam, a 5-centimeter indurated mass is visualized distal to the dentate line in the anal canal, and enlarged inguinal lymph nodes are present. Interesting. Tissue biopsy shows a tumor composed of eosinophilic squamous cells with areas of keratinization. This is your code word. Everybody should know when you read something like this, the website expects that you know what that means. So you have to memorize that feature. Which of the following is the next best step in management of this patient's condition? A, local excision. B, HIV testing. C, CEA level. D, APR, abdominal perineal resection. E, neoadjuvant treatment, or chemotherapy, I'm sorry, neoadjuvant chemotherapy specifically. All right, let's take a look. He's a young patient, no family history, no obvious risk factors based on what's listed in the history, but yet, significant finding on pathology that is, should already have identified as a specific type of malignancy. And the question is, what do you do next? Remember, next best step, not how are you going to manage the patient. Next best step in this setting after the patient walks into your office. And I am very happy to see that at least 51% of people answered this correctly. Okay, exactly. So the pathognomonic finding is the pathology. So anytime you hear a tumor with eosinophilic squamous cells with area of keratinization should essentially tell you this is anal cell cancer, anal SCC, squamous cell cancer, carcinoma. So why would a 25-year-old have anal cell cancer? One of the major risk factors is HIV. So clearly the next step is really diagnosis and staging. And among all the answers, the only one that is really diagnosis/staging is HIV, right? Because CEA level is not specific to anal cell cancer. This is adenocarcinoma, and not even, that's not something that you routinely do for anal cell cancer. And then the other options are about treatment. local excision is not correct in this particular case, because the next best step in treatment would be the Niagara protocol, which is neoadjuvant chemoradiation therapy, not just neoadjuvant chemotherapy. So that was actually a curveball. E was a curveball, which was the second most common answer. So I know if you're not paying attention, you would get caught. It's like, yes, the next best management would be neoadjuvant chemoradiation therapy, but that's not what they gave you as an option. And APR is no longer indicated for primary treatment of anal SCC. Good. Okay, next. An 18-year-old man is found to have a germline mutation in the APC gene. He is currently asymptomatic. He is scheduled for a colonoscopy during which he is found to have colonic polyposis. Which of the following is the most appropriate for screening this patient? For screening in this patient? A brain MRI at age 25. B, an EGD at age 25. C, an EGD now. D, a CT scan of the abdomen and pelvis at age 25. Or E, a CT of the abdomen and pelvis now. They love questions on FAP. Anything that has to do with epigenetics of colorectal cancer is going to be popular at AppSites and colorectal boards. So you get to memorize a few things here, a few genes, a few presentations, through guidelines. They're pretty straightforward. And then you just make yourself a couple of tables and review them frequently, because these are really relevant to clinical practice. We see those patients, we screen them every day in the office. Okay. 51% were close. Yes, excellent. And you can see the explanation here. Again, these are the kind of thing you have to memorize for FAP. It's patients really have to be screened starting age 10 to 15 for colonoscopy, because by the age of 39, if you haven't been screened, they will develop cancer. It's inevitable. It will happen. And an EGD is because of the incidence of duodenal cancer is significant. And we usually recommend they get screened at the age of 20 to 25 or earlier if they've been found earlier to have colonic polyps. So this is a case in this case. He's 18. He shouldn't be screened until the age of 20 to 25, but he was found to have colonic polyposis. So by definition, he needs to be screened much earlier because he's at increased risk. And then the other, one of the popular questions here was 12.5% of you said, 12% said CT of the abdomen pelvis now because we're concerned about desmoid. You heard that from the previous section. Desmoid are these intra-abdominal tumors that can be very locally aggressive and invasive. But in the absence of symptoms or family history, it is not recommended to screen with a CT scan. So it would only be screened if the patient was symptomatic or had a family history of desmoid. So that's one of those things you just have to learn and memorize. It will come up time and again. Okay, next question. Oops. Okay, we're on a run here. A 72-year-old man diagnosed with stage 2, specifically T3N0M0 rectal adenocarcinoma. He presents to the office 8 weeks after completing neoadjuvant chemotherapy and radiation. He is restaged, and this tumor now is found to be downgraded to a T2N0M0, 3 centimeters from the anal verge. He's scheduled for an APR resection. During the perineal resection, the ischiorectal fat is being dissected off the specimen. Which of the following structures is used to guide this perineal dissection? Again, which following structures is used to guide the perineal dissection? Think about palpation, what you feel for when you're doing this dissection from the bottom. A, sacral promontory. B, coccyx. C, ischial spine. D, prostate. Or E, mesorectum. For the record, this question makes me very angry, Michael, because we would be able to perform a transanal total mesorectal excision with intrasphincter resection and save this patient his sphincters if he was a candidate in terms of baseline continence. But we're not talking about this today. So answer, yeah, but I have to assume he's incontinent or has poor continence, so that's why he's not getting sphincter salvage. But yeah, so some difficulties with one, and I can understand it. What you have to think about if you have not done these procedures and served as a part of the perineal team is you think about this is a 2-team approach. The abdominal surgeon starts from the top, either laparoscopic open or robotically, and dissect. And during that dissection from the top, some of the landmarks are sacral promontory posteriorly. You're right above the sacral promontory as you dissect the mesorectum. And other landmarks are the prostate. Now, when it comes to the bottom, it's pretty blind. When you start your dissection, you close the anus off. You start with an elliptic incision surrounding the anus. You want to be outside of the sphincters because you want to make sure you have negative margins. And so there's really no landmark. There's only one landmark that is really helpful at that time. You can't really feel the prostate or the vagina. I mean, you see that you feel the vagina, but in a male, you cannot feel the prostate. And so one of the dissection tips, landmarks, is a coccyx posteriorly. You can feel the tip of the coccyx, and you know to stay right above it will essentially take you straight to the plane at the level of the levator muscles. And the levator muscles is really important because you're going to have to transect it. Ischial spine is a good guess. You would only really feel or use it as a landmark if you're doing a wide, what we call a wide APR. If the patient has a very locally advanced cancer that's invading into the ischioanal fats and even beyond, and the levator is completely involved, you have to go outside the levator. So you can't just transect the levator. You have to go outside, what we call the extra levator dissection. So more aggressive. In this particular case, you come across the insertion of the levator on that side at the level of ischial spine. But otherwise, it's a coccyx. You'll feel for it, and it will be your cue of where you are posteriorly. Very important landmark. Next question. A 50-year-old man presented to the clinic after his first colonoscopy in which a serrated polyp shows dysplasia and was found and biopsied. He has no known family history of cancer. Which of the following molecular changes is associated with the best prognosis for this patient? A, presence of the CpG island methylator. B, an MLH1 mutation. C, BRAF V600E mutation. D, APC mutation. And E, KRAS mutation. I feel your pain. This is pure memory. We have to learn this again. I went through this when I recertified for my colorectal boards. Epigenetics of colorectal cancer is a must know. This is the things you have to just memorize and know them. Okay, so where are we? Didn't expect any better. This is a tough one, guys. You just have to remember that MSI, so what you heard of microsatellite instability, MSI tumors, which are associated with MLH1 mutation, are the best prognostic ones. So it's bad to have Lynch syndrome in general, but it's not so bad when you have colorectal cancer and Lynch with an MLH1 mutation, because it actually has a better prognosis than when you have any of those mutations. APC, as you heard, you get cancer at 39. This is just a polyp that's going to transition to a cancer. But the question is, how is the patient going to do long-term? So you just have to memorize MLH1 mutation, which is MSI instability type of tumors, do better than any of the other ones, especially the KRAS mutation. You hear about KRAS all the time, KRAS mutation, as opposed to KRAS wild-type tumors don't respond as well to treatment. 5-FU based and EGFR antagonists, they don't respond well, so they're difficult to manage. Okay, this was by far the toughest one, so I totally expected this. Don't feel bad. Next question.
All right, sorry, just reloading here.
Okay. 10, yes. A 48-year-old man without a significant past medical history presents 1 week after LAP-API for acute and complicated appendicitis. His surgical pathology reports reveals a 2.5 centimeter appendiceal adenocarcinoma invading the submucosa. Given these findings, which is the most appropriate next step in this patient management? A, completion right colectomy. B, colonoscopy. C, total colectomy. D, chemotherapy. And E, no further management required. Now, you've had a similar question before, so you should have learned a strategy from the previous question that we had. Next best step in a patient with incidental finding of an appendiceal carcinoma on specimen. Next best step in cancer diagnosis. What do you do next? Oh, come on, guys. Yeah, so the next step is just like the previous case. It's staging. This is cancer. You have to stage before you treat. You have to know whether or not it's spread, right? So the 2.5 centimeter invading the submucosa tells you it's a T2 tumor. but it doesn't tell you the nodal status. You don't know whether or not the patient has metastasis. You have to figure that out before you treat. So that's why colonoscopy is the next best step. Okay, of course, he doesn't have CT scan there. He doesn't have, any other tumor markers like CA, CA19. You don't have any of those markers there, but this is the only diagnostic option that you have. So that's what you have to take. You have to screen for any additional tumors. So that's a tricky question. Not really. The next one was completion right colectomy. You're absolutely right. This would be the next step in management. There's no question about it. But this is not what they ask. So this is a trick question. You have to read and really understand. They want you to think about diagnosis and staging. Again, diagnosis and staging takes precedence in those questions. And then no further management is not acceptable. These appendiceal adenocarcinomas can be quite nasty. So these, because they have a high rate of positive lymph nodes, usually we recommend going back and doing a proper colonic resection with lymphadenopathy. So that would not be inappropriate to just watch it. Okay, a 53-year-old undergoes a CT scan of the abdomen and pelvis for nausea and vomiting after returning from an overseas trip. The CT demonstrates findings consistent with the gastroenteritis and a 1 centimeter mass on the distal ileum. After the resolution of his gastroenteritis, he undergoes a diagnostic laparoscopy, whereby a 1 centimeter mecal diverticulum with a soft, narrow base and no palpable abnormality is found in the distal ileum. No other lesions are found. What is the most appropriate next step in management? You're in the OR, and this is what you find. A, perform a diverticulectomy. B, perform a segmental small bowel resection. C, terminate the procedure and perform a mecal scan. D, terminate the procedure and manage expectantly. And E, perform an ileocecectomy. Also, they love mecal diverticulum questions. You're always going to have one. And same thing, the recommendations are very clear. These are the kind of things you just have to memorize the criteria for intervention, when, in whom it's been codified. Oh, okay. Well, you will memorize after tonight. Only 22 points. Only 22. I know you'd think you'd just take it out, but the answer is no, because there's more risk than benefits in doing so. You can narrow the bowel, you can cause a staple line bleed, you can do all. So essentially, there's no benefit in taking it out. So the criteria for resection are pretty codified. You can see here. In kids, of course, you take it out, but in adults under 50, essentially depends on your sex. In males adults, you take it out because there's a high risk of complication from the diverticula. In females, you only take it out if there's something like a palpable abnormality or a fibrous band or something, or a wide neck. But if you're over 50, like in this case, all adults, males and females over 50, you only take it out if there's a palpable abnormality, which they tell you was pertinent negative in their description. Again, you just have to memorize this. Sorry, guys. And mecal scan is not appropriate because the patient is not bleeding, but none of you really picked that option, so that's good. Okay. Last question. A 62-year-old man presents to the emergency department with acute left lower quadrant pain. Vitals are normal. On exam, he has severe tenderness localized to the left lower quadrant, but his abdomen is otherwise soft and non-distended. A CT abdomen pelvis with IV contrast shows a small amount of free fluid and a small amount of free air along the sigmoid colon. Patient is admitted and treated non-operatively with IV ceftriaxone and metronidazole and bowel rest. 4 days later, his pain worsens. He's found to have diffuse abdominal pain, guarding, abdominal distension. Repeat CT scan shows a large phlegmon at the lower abdomen and pelvis. His vitals and pulse rate are 92 per minute. Blood pressure is 121/69. Temp is 30.8. Oxygen saturation is 92% on room air. Which of the following is the most appropriate management for this patient? I love this question as well. A, continue non-operative management with the same antibiotics. B, continue non-operative management and broaden the patient antibiotics. C, laparoscopic lavage with a diverting loop ileostomy and placement of drains. D, laparoscopic lavage followed by elective sigmoid resection in 6 weeks. Or E, sigmoid colectomy with primary anastomosis and a diverting loop ileostomy. Oh, I can't wait to see how this is tackled. There's some really important information in that description. Most importantly, the patient, of course, deteriorates, right? Fails to respond to non-operative management, but he's not unstable. He is not hemodynamically unstable. So you have options once you decide to pull the trigger and operate, right? So the big question here is, how do you manage this in the OR in a patient who's otherwise not unstable, stable, but he's not well? There's a phlegmon, there's bad diverticulitis. What do you do next? Let's see. Oh my God, I should take a picture of this. Michael, take a picture to show that actually our residents are aware of the guidelines and level 1 evidence coming from all EAS, SAGES, and ESCS recommendations. I am so proud of you guys. You have no idea. So yes, the answer is sigmoid colectomy. If you can, the patient remains stable, it absolutely, and the tissues are good quality, and you have the expertise, please, by all means, put it back together, even laparoscopically. Sometimes you can do it. And then the option of diverting loop ileostomy is not mandatory, but a lot of us will prefer to divert them. It's much easier to reverse, as you know, an ileostomy than to reverse a Hartmann's procedure. The key is to stay away from a Hartmann's procedure. The other option of lap lavage, I thought were really good to have because they're still relevant in the right setting, but not in combination with diverting loop ileostomy. That's never been recommended by any other surgical societies. Lap lavage by itself also is not recommended to be followed by elective sigmoid resection. The idea is to avoid sigmoid resection with lap lavage. So the way it's phrased is not appropriate, but I can see why. So lap lavage is still a valid option by itself to avoid a resection or avoid a diversion, but it's fallen out of favor in the US because of an increased incidence of having to, additional reintervention in patients, such as having to operate on them because they don't respond after lap lavage. So, but I don't have to tell you that because you already know it. We'll stop now. Thank you.
Dr. Sylla, a distinct pleasure to have you. That was a lot of fun, and thank you for sharing your intricate expertise with us. So thankful.
Pleasure.
And safe travels as well to you.
Thank you. Bye, guys.
I'd like to welcome back my co-host, Dr. Haskins, who will introduce our final presenter.
Yes, so last but not least is Dr. Shanley Deal. She is in Seattle, Washington at Virginia Mason Medical Center. She is an MIS and bariatric surgeon, and she is also an associate program director at her institution. And she will be going over small intestine, biliary disease, and flex endo questions with us tonight. Thank you, Dr. Deal, for being here.
Thanks, everyone. I get to be the closer, which is always the fun role. I stand between you and the rest of your evening. So let's see what we can learn from these final questions. I know you guys have probably hit a little bit of a mental lull, so hopefully I can wake you up a little bit. So let's dive right in. A patient presents with a several-week history of poor oral intake and bloating. An upper GI series is performed, which shows a smoothly contoured submucosal mass in the mid-small bowel, causing an obstruction. So there's some real key phrases there. Which of the following is most accurate in regards to this mass? The mass should be biopsied to confirm the diagnosis. B, it is associated with a defect in the G protein receptor KRAS. C, the most common location in the small bowel is the jejunum. D, it arises from motilin cells of the GI tract. Or E, most tumors are inherited in an autosomal dominant basis. Let's start the poll, see what you guys think about this. This is a good warm-up question. Just kind of nice. Looking pretty good so far. Give a couple more seconds here to let you guys ring in. All right, let's look at our explanation here. Great. So the bottom line is most GISTs are in the stomach or in the jejunum. And so the key thing about this question is it's kind of leading you towards that GIST description, but it's in the bowel. And so you have to remember, and some of that's rote memorization, but you have to remember where in the small bowel are you most likely to find a GIST. And they use those smooth contoured submucosal small bowel mass key phrases that are always there when we're talking about GIST in a question stem. And instead of arising from motilin cells, they come from everyone's favorite cells, the interstitial cells of Cajal. And it's a defect in the c-KIT tyrosine kinase receptor, which was discovered at my alma mater, OHSU. So one of my favorite questions to start us off. Let's go on to the next one.
Oh, I didn't know that connection to OHSU.
Yeah. They hammered it into us when we were medical students. I still haven't forgotten. All right, here we go. So a 69-year-old male presents to the emergency department with a 3-day history of worsening abdominal pain, nausea, and vomiting. The patient reports that the pain was initially in the right upper quadrant, but over the last 24 hours, the pain has been diffuse and more severe. He has not passed gas or had a bowel movement since yesterday. Abdominal X-ray reveals multiple air fluid levels, a round shadow in the distal small bowel, and air in the biliary tree. CT imaging confirms diagnosis of gallstone ileus caused by a 3-centimeter stone and reveals moderate inflammation surrounding the gallbladder. What is the best next step in management of this patient? And that's the key thing. So admission for non-operative management with bowel rest and NG tube decompression, XLAP, enterotomy with retrieval of the stone alone, endoscopic removal of the obstructing stone from the ileocecal valve, XLAP, enterotomy, retrieval of stone, cholecystectomy, and closure of cholecystoenteric fistula. Sounds like a lot. XLAP and small bowel resection. So let's see what you guys think. Yeah, I had a feeling you guys would do pretty well with this one. Great. Yeah, everyone likes this question. Okay, show explanation. Great. So you guys did awesome. It is XLAP with enterotomy and retrieval of the stone alone. And really the key thing about this case is that if there is concurrent inflammation, then doing a cholecystectomy at that index operation is usually very difficult and not recommended when you're really trying to relieve the inciting incident, which is the small bowel obstruction. And that should be the focus of the operation. Let them recover from that and then consider next steps down the road. So it's the safest thing. And there are some, key factors in the explanation here that are helpful in regards to how the enterotomy should be performed, which should always be in a longitudinal fashion along the antimesenteric border so that you can extend that incision if you need to in order to extract it. And that's really the other thing you should think about is closing it in a transverse fashion. They also highlighted that. That might come up on another question. All right, next question. Which of the following is the most common type of symptomatic intussusception? So keywords being most common and symptomatic. Colocolic, appendicocolic, ilioileocolic, ileocolic, and ilioileal. That's a tough one to say.
Say that 10 times fast. Yeah.
I know, this could be a new challenge. Let's see what everybody thinks. Good job. Everybody's weighing in. A lot of takers for D, ileocolic. Let's check our explanation here. You guys nailed it. That is the most common type of intussusception, and it is the most common to be symptomatic. So the nice thing about this question is it does review all the others. So if you haven't run into it, haven't seen it, or thought about it in a while, it's a good one to kind of run through. So colocolic intussusceptions are usually associated with malignancy, and it's quite rare. And then an appendicocolic intussusception is exceptionally rare, and it kind of sounds rare, right? Most of us haven't heard anyone talk about that very frequently, so it's helpful to kind of gloss over that when you're reading the questions. And then ilioileocolic is the second most common type of intussusception, and that's only in about 10% of patients. So it kind of helps you arrive at that. And then answer E, ilioileal, is exceptionally rare, and it's usually more related to post-op adhesions, Meckel's, Crohn's disease, some other pathophysiology. And so we can move on to the next question now. I hit all my highlights. All right. A 53-year-old man presents to the ED with 2 days of epigastric and right upper quadrant pain that radiates to his back. He has a pulse rate of 120, a blood pressure of 105/62, and a temperature of 102.9. His labs are significant for a white blood cell count of 23, amylase of 4,000, AST of 400, ALT 500, T-Billy 4.4, and a lactate of 4.5. A right upper quadrant ultrasound identifies gallstones, dilated intra and extrahepatic ducts, and evidence of pancreatitis. A CT scan confirms the diagnosis of acute pancreatitis. Additionally, there is evidence of pancreatic necrosis with no evidence of air within the collection and a 4 centimeter ill-defined semi-solid collection within the lesser sac. Which of the following is the most appropriate next step in management of this patient? So here we have another next step question. Really the safest next step is going to be your answer. So A, initiation of antibiotics and CT guided drain placement into the retroperitoneal collection. B, initiation of antibiotics and endoscopic retrograde cholangiopancreaticography with sphincterotomy and biliary stent placement. I should have said ERCP, guys, instead of reading the whole thing. C, initiation of antibiotics and endoscopic cysgastrostomy, one of our favorite procedures here at Virginia Mason. D, perioperative antibiotics and laparoscopic cholecystectomy with IOC 2 to 3 days after resolution of abdominal pain. Or E, immediate open necrosectomy with debridement of the retroperitoneal collection. That's a favorite of our University of Washington colleagues across the street. So we've got some fun options in here. What do you guys think? What should we do? What is the safest next step for this patient? People are thinking a little bit. The votes are coming in. That's good.
It's like election night. We're just waiting with bated breath.
It is. We're just waiting for the final say. All right. So pretty similar to the responses on TrueLearn, which is helpful. You guys are spot on. So B is the correct answer. It is initiation of antibiotics and ERCP with sphincterotomy and stent placement. And, you know, this is a little bit of a tricky question, so I can see why some people would choose A, because it does seem like a conservative, safe next step as a potential option. But the key is that you have to have decompression of the biliary system. And if you just place the drain and do antibiotics, we're not actually resolving the obstruction. And so you really need to resolve that obstruction, and the ERCP with stent placement is what's going to get you there. So that's really why that next step is necessary to help relieve it. And then a cysgastrostomy, just in case people are curious about that or wondering about it, really those are reserved for patients that have a mature, more formed pseudocyst, or if there's going to be repeat debridements endoscopically. So that's another reason. And so most board questions are really not going to incorporate that. It's a kind of higher level question. An immediate open necrosectomy with debridement of the retroperitoneal collection is really too aggressive. So definitely not the first step. All right, next question. A 37-year-old woman presents with abdominal pain, nausea, and vomiting. As part of the patient's workup, an ERCP is performed. Which of the following is the most likely cause of a benign biliary stricture? I love this question. A, choledocholithiasis. B, chronic pancreatitis. C, previous cholecystectomy. D, primary sclerosing cholangitis. Or E, portal hypertension. What do you guys think? Most likely cause of benign biliary stricture. All right. So it is previous cholecystectomy. So common things being common, a lot of people get their gallbladder out. And strictures can happen from ischemic vascular injuries, prior common bile duct injuries, other biliary injuries or impingement. And so the most common reason is actually iatrogenic from a previous cholecystectomy. You guys are spot on with your second choice being A. So A is potential to cause biliary strictures if they cause injury or if there are other issues related to recurrent ERCPs. And then PSC does cause strictures, beating and irregularities, but it's a malignant cause. It's not a benign cause. So that's the number one reason to eliminate that answer right off the bat. So that's the other thing to think about. And then cholangitis is the most common presentation for a biliary duct stricture when people do present. And that can lead to cirrhosis and portal hypertension for that last question. All right, number 6. A 45-year-old man is incidentally found to have a 1.2 centimeter gallbladder polyp on a surveillance CT scan performed for follow-up of a resected colonic malignancy. He does not have any abdominal pain or symptoms attributable to the gallbladder polyp. What is the next best step in the management of this patient? A, reassurance and observation. B, laparoscopic cholecystectomy. C, MRI of the liver and gallbladder. D, repeat CT scan in 6 months. Or E, repeat an ultrasound scan in 6 months. So D and E sound, very similar. That's one thing to think about. MRI, lap chole, or reassurance. So kind of a good spread here, but if you're a good test taker, you can kind of figure this one out. And you guys are doing a good job already.
Dr. Deal, there's a question from the last one about why is a biliary stent needed in addition to stone extraction and sphincterotomy?
Ah, that is a good question. In general, if you have a stricture, you're going to need to place a stent. And usually, not usually, but oftentimes the stent alone will help resolve that stricture over time through essentially forced dilation by having that stent in place. And if the stent is a plastic stent versus a metal stent, there's lots of discussion about that, and they didn't specify. So there's a reason why they didn't specify in the question stem to not confuse anyone. But overall, that stricture isn't going to be resolved. So you do need to have a stent there to help relieve it.
Thank you.
So that you can have continued forward biliary flow, essentially. And the sphincterotomy isn't enough to have that. You want to stent it open.
All right, we've got
All right.
6, Shanley.
Here we go. Laparoscopic cholecystectomy is the next best step in management. And the key for this question is really indications for gallbladder polyps. So you do have to memorize these, and it's helpful to review and tuck those numbers away. But cholecystectomy is really recommended for polyps in the 6 to 9 millimeter range. And anything over 1 centimeter is going to have a higher risk of malignancy. So in general, anyone that has a polyp that's 6 millimeters or greater should be offered cholecystectomy based on consensus guidelines. Anyone under 6 could be offered serial imaging and observation to see if there's interval growth, and those are safe choices. People are more likely to have malignancy if they're older. Obviously, there's certain characteristics that can be more concerning. And then interval growth that's rapid is more concerning as well. Or if there's any sign of potential invasion into the wall of the gallbladder and location of the polyp, whether it's on the liver bed side or anterior side of the gallbladder. And imaging is very characteristic for these. This is a great picture. If you Google some of these photos before your ABSITE or board exam of kind of high yield images, this is one of them because it doesn't fall. It's not dependent. It's staying up like a stone would fall, for example. Let's go to our next question here. A patient presents to the emergency department with new onset jaundice and right upper quadrant pain 3 days after undergoing laparoscopic cholecystectomy for biliary dyskinesia. A right upper quadrant ultrasound shows dilated intrahepatic ducts that are shown in the figure. Labs are as follows. T-bili is 8.2, direct bili is 6.4, alkaline phosphatase 300, white blood cell count 8.7, hemoglobin 11.9. What is the most likely etiology causing the patient's current condition? A, burn injury to the common bile duct causing stricture, so iatrogenic injury. B, cholangitis. C, cystic duct stump leak. D, misidentification of normal anatomy at the time of his surgery. Or E, retained common bile duct stone. And this is really one of those questions where you need to go back and look at every detail in the question stem to figure out what will eliminate certain responses. I think you guys got a good mix for D and E. I had a feeling it would kind of land in that realm for this question. It's a harder one.
All right.
Okay. So the cause of injury to the bile duct is going to be D, misidentification of normal anatomy at the time of surgery. As many as 75% of injuries are missed at the time of the operation. And like we had previously discussed in our biliary stricture question, about 80% of benign strictures are caused by lap coli. So that can kind of help get you to this question again. And then the imaging, right upper quadrant imaging, it's helpful, once again, to just kind of look at these and have an appreciation for what dilated ducts look like. They were helpful in the questions and that they gave you some of that information ahead of time. We can go to the next one. Okay, which of the following statements best describes the anatomy of the hepatic artery? A, the right hepatic artery originates from the SMA 40% of the time. B, the common hepatic artery becomes the hepatic artery proper after giving off the right gastric branch. C, the major bile ducts receive blood flow from contributions of the hepatic artery and portal vein. Or D, the hepatic artery lies within the portal triad, anterior to the portal vein and lateral to the bile duct. E, a variant of the left hepatic artery is an origin off the left gastric artery. So this is a rote memorization question, but a really good review of complex upper GI anatomy. Let's see if you guys can get it. All right, let's look at our explanation. I think we got most folks weighing in. Very good. There's a nice picture here. Overall, hepatic arterial anatomy can be variable. It's good to review what some of those most common variants are beforehand. And a variant of the left hepatic artery is an origin off the left gastric. So that's just one to memorize. And it's helpful to have these kind of tucked away because they are highly testable questions. And just to review, a variant of the right hepatic artery originates from the SMA, which occurs approximately 10 to 20% of the time, not 40%. So that one was kind of devil in the details for A. So I think you guys picked up on that it's just not that frequent of a variant. Okay. Which of the following is true of enterohepatic circulation? A, conjugated bile acids are absorbed in the colon. B, approximately 50% of bile acids are excreted in the stool with each cycle of enterohepatic circulation. C, the majority of bile acids are absorbed by active transport in the jejunum. D, poor absorption of bile acids leads to vitamin B deficiency. Or E, primary bile salts are conjugated in hepatocytes with glycine and taurine. Some fun ones here. Really hearkening back to your medical school knowledge, which is great. Keep us accountable for all those cycles and pathways we memorized. All right. I think most of you have weighed in. Very good. You guys had a pretty strong response there. A couple takers for B and C, just like on TrueLearn, which is very common. And like I said, this is one where you really have to just review it. So the majority of conjugated bile acids are absorbed by active transport in the TI, while the remaining are deconjugated by gut bacteria and then absorbed in the colon or excreted. So you have to remember that kind of difference between conjugated bile acids, where they can be actively transported versus deconjugated by bacteria. So that's kind of the flow through the system. All right, next question. A 54-year-old man presents with a 4-month history of intermittent abdominal pain, emesis, and weight loss. The patient also reports dark-colored urine, clay-colored stool, and pruritus. Physical exam reveals yellowish discoloration of the skin and mucous membranes. Lab workup shows elevated total bilirubin, alkaline phosphatase, and anemia. CT of the abdomen reveals the following. What is the most likely nutritional deficiency expected in this patient? So I like this question because as you're reading, you're starting to think about the pancreas and what's going to happen. And then they throw this nutritional deficiency question at you. And a lot of questions are written this way. So you have to think about what pathophysiology is going to result in your answer. And so they've given you some choices here. A is iron, B, vitamin B12, C, vitamin K, D, protein, or E, fat. Let's see what you guys think. Good job. All right. So indeed, it is vitamin K. And the key to this is it's a fat-soluble vitamin. So fat-soluble vitamins like vitamin K are going to be very challenging to absorb in the absence of bile. So with biliary obstruction, you're not getting enough bile flow to be able to absorb those properly. So ADEK could be low, and K is the only choice on there. So one thing you can kind of tuck away is if they're asking a question about something like this and nutrition, if you only see one of A, D, E, and K available as an answer choice, it's probably the right one, and you should think about it and go back and look through them.
Good tip.
Yeah, it's a good one to tuck away. These are common questions. All right, let's go to our next question.
It's loading here.
No worries. The good news is I'm going to get you guys done a little bit early, which is great for everyone.
All right.
All right, here we are. Question 11. A 52-year-old woman presents to her PCP with intermittent abdominal pain, hot flashes, and diarrhea. Her history is significant for laparoscopic appendectomy as a child, and she has high blood pressure. Her physical exam is significant only for mild generalized abdominal pain without rebound or guarding. So after an extensive workup, her 5-HIAA and a 24-hour urine sample is found to be elevated. A diagnostic colonoscopy is unremarkable. Which of the following is the most likely location of a neoplastic process in question for this specific patient? A, appendix, B, stomach, C, jejunum, D, ileum, or E, rectum? Let's see what you guys think. This is a little bit of a spread here. Okay. Let's show our explanation here. All right, so overall the answer is ileum. And part of the question stem tells you that the colonoscopy is unremarkable. So that helps you eliminate the rectum. You have to trust your endoscopist and say, okay, it's clear. There's probably nothing there. And then that narrows you down to A, B, C, or D. And most of you were kind of clustered in the ACD range. So overall, the carcinoid tumor distribution in terms of location is rectum most common, and then small intestine second most common. And ileum is more common than jejunum. So you just have to memorize that, and thanks for highlighting those. Those are really the top ones, and then the ones before that just become less common. Okay. A 5-year-old girl was brought to the emergency room with a palpable abdominal mass and tenderness in the right upper quadrant. She has scleral icterus and her serum bilirubin is elevated. Her mother reveals this has happened before, but they have lived in an area with poor access to medical care and recently moved. Abdominal MRI reveals a large intrahepatic biliary cyst extending off the main left hepatic duct with engorged biliary radicals and a small fusiform dilation of the common bile duct. The most appropriate next step in management includes A, simple cyst excision, B, endoscopic sphincterotomy and biopsy, C, cyst resection and choledochojejunostomy, D, excision involving partial hepatectomy and Roux-en-Y hepatico-J, or E, liver transplantation. All right, tough question.
Some discussion
Yeah,
on this
there
one.
is some discussion on this one. All right, we'll spend a little time on this one for our review. So this is a type 4A choledochal cyst, and it involves extra and intrahepatic duct dilation. So the management of choice is actually completes resection of the cystic disease, including the partial hepatectomy. So that's really the key feature in the question stem when you're reviewing choledochal cysts. And you do have to memorize your Tadani classifications for these so that you know where you're looking and what they're describing and how to treat it. So type 4A is both. And so you really do have to remove a portion of it. And because the rest of the normal is reasonable, they don't need a liver transplantation. I know some of you went for that, but she's young, she's 5, she has isolated disease segments that can be resected safely with a large portion of liver based on the question stem. Okay. A 61-year-old man undergoes a partial hepatectomy for a symptomatic hemangioma in segment 6. The gallbladder is also removed for symptomatic cholelithiasis. 6 months later, the patient is admitted for ascending cholangitis and is found to have a benign stricture of the common bile duct. Which of the following is the most likely explanation for these findings? A, iatrogenic injury to the replaced left hepatic artery. B, iatrogenic injury to the portal vein. C, iatrogenic injury to the anterior surface of the common bile duct. D, iatrogenic injury to the lateral surface of the bile duct. Or E, cholecystectomy. You guys made it, answering your last question. Good job. All right. So overall, this is really a question about where does the blood supply to the common bile duct come from, and it's segmental. And you can see that you've got your 3 and your 9 o'clock marginal arteries that kind of run alongside the bile duct, and it's important to remember that. So iatrogenic injury to the lateral surfaces of the bile duct are actually the most common reason, and it's why like full exposure and identification of those sutures that are placed at the time of reconstruction is really important so that you don't damage the blood supply to the common bile duct. And so that's just something you have to memorize. And some of these other question stems are pretty easy to eliminate, like iatrogenic injury to the replaced left hepatic and the portal vein. Those aren't great options, which you guys picked up on, but C and E don't really explain the findings, whereas D does. All right. Thanks everybody for your attention. It was great taking you through to the end here. I'll let Dr. Awad wrap us up.
Dr. Deal, thank you so much. Phenomenal discussion of some very complex topics, but really appreciate your expertise. And that concludes all of our questions. What a tour de force. We went through a lot of material there, but also please remember, team, all of tonight's webinar will be recorded, and we will send out a notice when it is made available on the SAGES website and SAGES YouTube channel. I want to give a sincere thanks to my co-host, Dr. Ivy Haskins, and all of the phenomenal panelists who shared their time, their expertise, the exam-taking tips with us this evening. A special thanks to Dr. Sylla, our SAGES president, for making these sessions possible and supporting us this evening. I do want to also just remind folks about our SAGES annual meeting coming up in April. Again, one of the most phenomenal meetings that you'll attend. A great time full of content, and again, one of our values of fun. And then finally, our second part of our ABSITE webinar will be in January 9th, 2024, where we'll cover the remaining ABSITE topics for you in a very similar format. Thank you again for being here. In the meantime, everybody, please stay safe, remain healthy, have a wonderful holiday season, and we'll see you in the new year. Thanks and good night.